All right, let's jump right in. We're going to talk about a drug that's been an absolute cornerstone in the fight against breast cancer. I mean, a true lifesaver for so many. But it also has this incredible, fascinating paradox right at its heart, which is why we're calling it the double-edged sword.
And that's really the core question we're digging into today, isn't it? How on earth can one single medicine be a powerful shield against one cancer, but at the same time actually raise the risk of another one? It sounds impossible. To get our heads around it, we first have to understand the enemy it was designed to beat.
So, let's start with the problem itself. What are we actually trying to stop here? Well, it all comes down to what certain cancer cells use as fuel to grow. Okay, so picture this. On the surface of our cells, we have these things called hormone receptors. The best way to think of them is like a tiny lock on a door. And a specific hormone, in this case estrogen, is the key. When that key slides into the lock and turns, it opens the door and tells the cell what to do.
Now here's the thing. In about 3 out of every 4 breast cancers, the cancer cells are just covered in these locks. We call this hormone receptor positive, or HR+, breast cancer. And what that means is, when the body's own natural estrogen finds these receptors, it's like a key turning in the ignition of a car, telling that cancer cell, go, 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 grow and divide.
And this right here shows you the problem perfectly. You see that estrogen molecule? It fits right into the receptor, and boom, it sends a signal that just fuels the cancer's growth. So the big question for scientists was obvious, right? How do you cut the fuel line to the engine?
And the answer, wow, it was a game changer. It came in the form of a truly revolutionary drug called Tamoxifen, which is part of a very, very clever class of medications.
Tamoxifen is something called a SERM. That stands for Selective Estrogen Receptor Modulator. And that word, selective, is the absolute key to this entire story. It means this drug is basically a master of disguise. In one part of the body, it can block the lock, and in another part, it can act like the key itself.
And check this out. Here's how it solves that first problem. In breast tissue, tamoxifen is designed to fit perfectly into that estrogen receptor. But here's the trick. It doesn't turn the key. It just sits there, jamming the lock, so the real estrogen can't get in. This basically starves the cancer cells of their fuel. In this situation, it's a perfect blocker, what we call an antagonist. But, and this is where the plot really thickens, that selective nature means it doesn't act like a blocker everywhere else in the body. Tamoxifen kind of leads a double life. To really get this paradox, you have to think about a tale of 2 very different tissues, because the drug's effect is completely dependent on where it is in your body. And the most important comparison for us today is between the breast and the uterus. In the breast, like we just saw, it's a blocker. It stops cancer. But in the lining of the uterus, it does the exact opposite. It actually acts like estrogen. Let's break this down with the scientific terms. So, something that blocks a receptor is called an antagonist. Something that activates it is an agonist. Tamoxifen is both. In breast tissue, it's an antagonist, our hero, the cancer fighter. Now, in bone tissue, it's an agonist, which is actually a fantastic side effect. It mimics estrogen and helps keep bones strong. But in the uterine tissue, it's also an agonist. It acts like estrogen there, and that can cause the uterine lining to grow thicker than it should. And that abnormal growth, well, that's where the risk comes from.
Okay, so tamoxifen isn't the only SERM in the game. To really see what makes it so unique, it helps to compare it to another similar drug called Raloxifene.
This chart is perfect for seeing this side by side. Let's just look at the first few rows here. You can see they're both SERMs, and most importantly, they both act as antagonists in breast tissue. That's great. It means both drugs are good at cutting the fuel to breast cancer cells. They also both act as agonists in bone, helping with bone density. So far, they look pretty similar, right?
But this is the critical difference. This is the whole reason we're talking about this. In the uterus, raloxifene acts as an antagonist. It's a blocker there too. And that means it doesn't stimulate the uterine lining, so it doesn't carry that same risk of endometrial cancer. That one difference in that one tissue is the entire paradox in a nutshell.
So this all leads to the most important question of all, the real-world calculation. How do doctors and patients weigh these incredible life-saving benefits against this very real but very specific risk?
You know, this quote from an expert really just nails it. For patients who have invasive hormone-positive breast cancer, the power of tamoxifen to stop it from coming back and to save lives is just tremendous. The key is to understand the scale of the risk you're taking on in comparison.
Now, when you look at the studies, you'll see a number like this. Tamoxifen increases the relative risk of uterine cancer by about 2.4 times. And let's be honest, that number sounds huge. It sounds terrifying, right? A risk that's almost 2.5 times higher is not something you just brush off. But relative risk can be really misleading if you don't have context.
So the most important thing to do is to look at the absolute risk. What does that 2.4 times increase actually mean for real people? This chart helps put it all into perspective, because we're starting with an event that's already really rare.
Here's the bottom line. Over 5 years, the baseline risk for uterine cancer is about 1 woman out of 1,000. With tamoxifen, that risk goes up to between 2 and 3 women out of 1,000. So yeah, the risk more than doubles, but it's an increase from a tiny number to a still tiny number. And for a patient whose life is being saved from a much more common and immediate threat like breast cancer, well, that trade-off often becomes very clear.
In the end, tamoxifen is an incredibly powerful shield in our arsenal against breast cancer. But like we said, it's a shield with 2 edges. And understanding this complex, selective science isn't just a cool biology lesson. It's really the heart of modern personalized medicine. It forces us to ask a much smarter question. Not, is this drug good, but who is it good for, and what are the precise trade-offs we're making?